can get the book.
Yeah, read it.
Order, demonstrating my own multifunctionality. I am now going to chair but not participate in the next debate, and I call Jim Shannon to move the motion.
Mr. Chairman, I don't know where my functionality appears in all this, but we're doing two debates in a row, but lovely to serve under your chairship. I beg to move that this House is considered the prevention of cardiovascular disease. I'm the party's health spokesperson, and I explained that in the last debate. This is a subject matter that I have a lot of interest in. I declare an interest as chair of the APPG on respiratory health as well, and these are one of the things that we focus upon. Back in 2019, the NHS long-term plan defined cardiovascular disease as the single biggest area where the NHS can save lives over the next 10 years. So 6 years on, and this statement still rings true. But are we any closer to arriving at the conclusion of that? I'm not sure. There are over 7.6 million people living with heart and circulatory diseases in the United Kingdom, and is responsible for a quarter of all deaths across the United Kingdom every year. It's one of the biggest killers. I'm very pleased to see honourable members here, and I want to thank them for coming. And I'm not quite sure when. Anyway, the PPS is here for the Minister, and we look forward to the Minister's contribution whenever that arrives. Very pleased to see the Shadow Minister in his place. I know he and I both seem to share debates regularly, and I'm very pleased to have him in his place, and also the Shadow Spokesperson for the Liberal Democrats as well. Thank you. In line with the predictions from the British Heart Foundation, by 2030 the prevalence of heart and circulatory conditions in the United Kingdom will have increased by 1 million, and by 2040 it will rise by 2 million due to a growing elderly population, the high prevalence of CVD risk factors, and improved survival from major CV cardiovascular disease events. It is most certainly the case that cardiovascular disease care in the United Kingdom is at a critical juncture. And it was very starkly illustrated, I believe, by Lord Darcy's recent independent investigation into the state of the NHS. I know we all are aware of that, and we'll be aware of some of the key points, which set out how nearly 50 years of progress to improve CVD outcomes has begun to reverse in recent years, and that can't happen. So again, I'll be seeking reassurance from the Minister in relation to that we're out to stop the reverse in recent years. The number of people dying before the age of 75 with CVD has risen to its highest level since 2010, whilst the association between poor CVD outcomes and health inequalities has also increased, with people living in the most deprived parts of the country being twice as likely to die from CVD as those in the least deprived. And there's something seriously wrong, Mr. Chairman, when we have those who just happen to be in a deprived area have a bigger risk of dying than those who don't. And this slowing of progress is creating enormous costs for the NHS and for society as a whole, including £12 billion in total healthcare costs and £28 billion across the wider economy due to premature death, long-term care, disability and other informal costs. A key challenge that is driving this relates to the high prevalence of CVD risk factors such as high blood pressure, obesity, diabetes, limited physical activity, air pollution and smoking. And as a diabetic, I declare an interest as a type 2 diabetic. I've had it for some almost 20 years now. And I understand the impact that can have upon others who are much worse off than me, but mine is controlled by medication, and I'm thankful to God for that. Raised cholesterol is another significant risk factor and is associated with 1 in 5 deaths from CVD, and just over half of all UK adults are living with raised cholesterol, significantly increasing their risk of heart attack and stroke. However, due to the lack of immediately obvious symptoms, high cholesterol levels often go undetected. So again, one of the questions I'd be asking the Minister or his department, and there are concerns that without immediate action, there could be a further tidal wave of CVD death due to the thousands of missing patients, in inverted commas, who are living with undetected and unmanaged heart and circulatory conditions. There are similar challenges in Northern Ireland. The Minister, the Chairman will know, and the Minister and the Shadow Ministers and others will know, I always give a Northern Ireland perspective because I think we're not. I think it replicates what happens here in the mainland, and that's the reason why I do it. But we've an estimated 225,000 people living with heart and circulatory diseases. Remember, we have a population of 1.9, so it gives you an idea of the perspective of this. And since the 1960s, significant progress has been made, with CVD deaths rates falling by 3/4. But this improvement has plateaued in recent years, and some 4,227 people died from CVD in Northern Ireland last year, including 1,133 people under the age of 75. So it isn't just an elderly person's disease, and I think I have to put that on record. The annual NHS expenditure in CVD in Northern Ireland is some 290 million, a colossal amount of money spent for it, while CVD's overall cost to the Northern Ireland economy equates to some 740 million each year. Those are massive figures. I think sometimes I know we shouldn't be looking at health in purely a financial point of view, but when we look at those figures, I think, Mr. Chairman, it tells us this. It tells us if we were working better with CVD and how to combat it, then I think the issue of finance would be reduced greatly. The impact upon the economy, number one, the impact upon the health service, number two. Northern Ireland faces similar problems when it comes to identification and management of CVD risk factors, with around 400,000 people living with high blood pressure, including 110,000 who are undiagnosed, while nearly half of adults, some 45% of adults in Northern Ireland, are not performing enough daily physical activity. In my own constituency of Strangford, the prevalence of hypertension, coronary heart disease and stroke is significantly higher than the rest of Northern Ireland, and it could well be the reason for that, Mr. Chairman, or because we have an elderly population in my constituency, because people tend to come and retire in the constituency that I represent. Despite these dire figures, both in Northern Ireland and the United Kingdom as a whole, there are, however, real opportunities available for us to reverse the trends and to help the UK to become a world leader in CVD, as at one stage it quite clearly was trying very much to do. To get there, though, it's clear that we have to start doing things rather differently. Recent years have seen a number of policy commitments from successive governments, but these haven't shifted the needle, haven't shifted the focus or the direction. And today's debate is to highlight the matter, but also to seek the help to address that. There was the NHS long-term plan from 2019, which set out ambitions to prevent 150,000 heart attacks, strokes and dementia cases over the next 10 years. But we are unfortunately, in my constituency and elsewhere, we're experiencing high levels of those with dementia cases, with those with strokes, and indeed those with heart attacks. And in Northern Ireland, unfortunately, the figures are incredibly high. Successive versions of NHS annual planning guidance have also encouraged local systems to prioritise CVD and address the significant inequalities that are associated with the disease. And whilst the last government's major conditions strategy, although not fully implemented, set out a series of robust principles to improve CVD care, including personalised prevention, early diagnosis, effective management of multiple conditions, integration of physical and mental health service, and tailored services to individual needs. So the strategy from the last government was clear. The strategy of this government, I think, is equally clear, but we do need to address some of the issues, and I will come to those as I go through my speech. What is lacking is a deeply embedded system-wide approach to CVD prevention that moves care upstream, is backed by sustainable long-term funding and deploys the latest technologies and innovations. Evidence that this approach has been lacking were starkly illustrated by the National Audit Office's recent report, which assessed progress in preventing cardiovascular disease, specifically focused on the delivery of the NHS health check. That is one of the main tools we have to enable early intervention on heart disease. The report concluded that there is currently no effective system for commissioning health checks, despite it being a statutory responsibility on local authorities. DHSC, local government, have weak levers to encourage primary care or other services to deliver health checks. So that will probably be one of my asks of the Minister, and I'm very pleased to see him in this place. I wish him well, and I know that we'll not be disappointed in his response as Minister to the requests that we have. During 23-24, only half of the eligible population attended a health check in 23-24, and only 3% of local authorities cover their entire eligible populations. Those are things we've got to change. So my request will be the statutory responsibility in local authorities, the primary care or other services to deliver health checks, and to increase the numbers of people who get checked. Action plan as well. I went on to say that this is not a satisfactory basis for delivering an important and potentially life-saving and money-saving contribution to population health, and that major improvements are needed if government is to embed them in a policy environment that promotes prevention rather than treatment. I've always been a believer, Mr. Chairman, in prevention rather than treatment. Diagnose early, prevent it at an early stage, stop the whole thing going further. Current approaches are also not sufficiently taking account of genetics and the role of inherited familial conditions such as familial, what's the big word here, hypercholesterolemia and cardiomyopathy in increasing CVD risks. Children are not routinely screened. GPs often fail to take account of people's family history, while many patients often report difficulties in accessing genetic screening. Going forward, patients and doctors need to be empowered to access genetic testing, secure a diagnosis, and then take the preventative measures, which clearly will help better health for the future, but also save money within the NHS. And I'm very pleased to see government's commitment to the extra £26 billion to the NHS, and it's something that I welcome, because I know that right across this great United Kingdom of Great Britain and Northern Ireland, we will all benefit from that. Mr. Chairman, with up to 80% of premature deaths from CVD being preventable, that's a figure we can't ignore. 80% of deaths from CVD are preventable. That's got to be a goal that we must try, I believe, to achieve. The importance of this area cannot be overstated, and the evidence shows that CVD prevention pays, with analysis from Heart UK estimating that merely improving the management of cholesterol, triglycerides and other lipids through increased uptake of NHS health checks, and by extension increasing the number of patients who are on lipid-lowering therapies, could deliver over £2 billion in annual savings for the NHS and wider society. I'm going to focus very clearly on the lipid-lowering therapies, because I think there is a solution in there which I would be very keen to see government taking on board. And whilst prevention spending is often deprioritised in favour of meeting short-term measures, it's exactly this kind of investment that is needed we are to deliver on this government's pledge to shift from sickness to prevention. I welcome government's commitment to do that, to shift from sickness to prevention. It's what I want from my party's point of view and from my point of view. Recent discussions that I've had with stakeholders in the area have revealed a number of key themes that will be crucial to delivering progress on CVD prevention. These include 5 of them in particular I just want to speak about at this moment in time. Securing dedicated and ring-fence funding for CVD prevention to enable targeted prioritisation of preventative approaches. Secondly, identifying at-risk patients through early detection and risk assessment strategies, including testing from birth and family cascade testing as well. And thirdly, developing comprehensive public awareness campaigns that empowers patients to self-monitor. And if we can have patients' participation in this as we go forward, that will be much welcomed. Fourthly, increase access to prevention services by moving them closer to home, including delivering more community-based diagnostic services as well. And fifthly, ensure timely implementation and consistent application of evidence-based clinical guidelines. In particular, there's a growing recognition of the potentially transformative opportunity that can be realised through wider awareness and recognition of another key CVD risk factor called lipoprotein A, and I'd mentioned now as LPA for short. LPA is a large lipoprotein made by the liver. Lipoproteins are parcels made of fat and protein. The job is to carry the fats around the body in the blood. With elevated levels of LPA are found in the blood, it serves as an independent, inherited and causal risk factor for CVD due to its pro-atherogenic, pro-inflammatory and pro-thrombotic effects. 1 in 5 people are estimated to have raised levels of LPA in their blood. This equates to some 13,400,000 people in the United Kingdom, or an equivalent of filling every seat in Wembley Stadium about 150 times. LPA is associated with an increased risk of several life-threatening events and conditions such as myocardial infarction, heart attack, stroke, coronary artery disease, peripheral arterial disease, and also heart failure. And sadly, these events are often premature. So if we have a way of diagnosing, of early prevention, of doing it better, then let's do that. And my ultimate request to the Minister will be that happens. In severe cases, which apply to about 12% of the population, raised LPA continues to be 2 to 4 times a higher risk of heart attack, stroke and heart disease. The prevalence of raised LPA is also typically higher amongst African and South Asian populations, a trend that is likely exacerbating existing health inequalities yet even further. Despite the huge numbers at risk, very few people know that they have a raised LPA, but if they did, then it would be preventative. If they did, we could have a diagnosis. If it did, we could ensure their lives would be better and longer living. And if we did, then we could reduce the cost on the NHS. The awareness of its role in contributing to CVD risk is low amongst the general public and healthcare professionals, so there is a need to raise awareness. And with a significant burden, there comes a huge opportunity to improve outcomes for a so far largely untreated and unserved patient population. In Northern Ireland, I want to mention, if I can, my constituent Dr. Paul Hamilton and also Gary Rolson. They're both consultant chemical pathologists at Queen's University of Belfast Health and Social Care Trust, and they're leading, at this moment, pioneering work in this area to proactively measure LPA levels in patients who are at risk of CVD. I'm always amazed, and I always like to tell a story. I think it's right to do so, Mr. Chairman, in relation to Queen's University. When it comes to research and development, they're at the forefront, and they're at the forefront in this, on the LPA, and as such, I would seek the Minister's discussions and interaction with Queen's University, because the recent audit of their testing programme has revealed that early measuring LPA levels does lead to a change in CVD management for a large number of patients. It also demonstrates that LPA testing and management can be implemented to improve population health and reduce the risk of CVD. When we look at those things, then I think quite clearly we see something that can even be done even better. Whilst there are currently no specific therapies for lowering LPA levels, the task force believes that there is a clear and growing case for taking action now to incorporate LPA testing and management within mainstream CVD prevention strategies. Several new LPA lowering therapies are currently undergoing late-stage clinical trials and could well be available in the very near future, pending the outcome of those trials. A really exciting way forward, exciting way to save life, exciting way to improve life. It is therefore vital that steps are taken to enable system readiness for these therapies and ensure that the NHS is in the best possible position to maximise their anticipated benefits. In the interim, there is a growing clinical consensus about the value of identifying patients with elevated LPA, and particularly knowing that the individual's LPA informs more intensive management of other cardiovascular risk factors, including blood pressure, lipids, glucose and power, and empower people to make a lifestyle change to reduce their overall CVD risk. Support the cascade screening of family, close relatives, again another positive way forward due to LPA's genetic status. There is quite clearly a way with technology, with innovation, to test more and to do more good for people. Tangible progress in this area could therefore play a key role in supporting many of the key principles that have been identified as being crucial to guaranteeing the future sustainability of the NHS, such as reducing pressure in the acute sector, delivering more personalised care, precision medicine, and capitalising on the pioneering innovation that has been led by the UK's life sector. More broadly, it can also support the government's ambitions right here in Westminster, to get people back into work by reducing the incidence of major CVD events, and that can prevent people from participating in the Labour Party. But with the LPA tests, with the early diagnosis, with the prevention, then it can support people. To be fair, Mr. Chairman, most people want to work. They want to have a normal life. It's not the fact is that the ones that I speak to, they're not seeking benefits for any other reason, and the fact that they're unable to work. National guidance, local implementation, but without formal recognition of LPA within national policy, the only LPA testing that takes place will be reliant on the work of proactive local clinicians. We need to make it the norm. We need to make it the things acceptable in the way forward. And those regional variations, unfortunately, are not acceptable. Local systems need clear direction from the centre to encourage them to start thinking proactively about how LPA testing and management could be incorporated in their local CVD prevention pathways. So what are we seeking? We're looking for a review of current CVD prevention and treatment pathways, assessment of where the LPA testing could be incorporated to deliver tangible benefits now, not later, now, and to maximise the benefits of LPA lowering therapies when these become available. Engagement with local specialists, lipid clinics and clinical laboratories to assess current levels of LPA testing, whether this aligns with agreed best practice, and consider what will be needed to upscale activity in the coming years, and to encourage local CVD champions to start thinking about the role of LPA in contributing to CVD risk, and disseminate that information about LPA within their local networks. In the task force call to action, the group identified several system barriers that are holding back progress in this area, and they are also applicable to the success of other health prevention strategies. And this includes NICE procedures and methodology. NICE's guideline methodology needs to take account of wider evidence criteria beyond that which applies to a specific treatment. In the case of LPA, Mr. Chairman, while specific LPA lowering therapies are not currently available, the task force believes that there is nonetheless a strong case for taking action now to proactively incorporate recommendations on LPA testing and management within the NICE guidance. If replicated across other disease areas, this more proactive and also anticipatory approach from NICE would help to improve the NHS system readiness for new innovations, new treatments, encourage the healthcare professionals to think more proactively about how a specific risk factor may be contributing to the overall risk, embed a more preventative mindset across the health system, reflecting the significant role of NICE in driving clinical behaviour. If we can improve it, it's cost effective, it's preventable, the early diagnosis makes out there, then we really need to look at it. The accuracy of health risk assessments, risk assessment tools, particularly in CVD, play a crucial role in supporting health prevention strategies. And with an accurate assessment of an individual's risk of experiencing a major CVD event, this can inform the most appropriate action to proactively manage and reduce that risk through a combination of treatment interventions, lifestyle changes as well, because we have to play a part, each of us individually. Going forward, it is vital that existing CVD risk assessment tools are updated to take advantage and account of LPA and its known association with a range of life life-threatening or life-changing cardiovascular events and conditions, this recognition will be essential to delivering truly holistic assessment of an individual's cardiovascular risk profile. I mentioned this, the standardisation of testing and reporting as well. I've highlighted this one, but I think it's important that we look at this. The success of health prevention strategies is also dependent upon the accuracy and the consistently diagnostic processes. In the case of LPA, testing should be conducted according to the best practice principles that have been set out by Heart UK. And I just wonder, has the Minister had a chance to perhaps talk to Heart UK? They've got some great ideas, some very positive ways forward, and I think it's a bit of a partnership, if I could say that, where we can work with them and deliver the therapies and the diagnosis and the prevention that we hope to do. In emerging therapies areas in particular, it is vital that there's a focus on encouraging greater diagnostic standardisation from the outset. Clinicians often get used to the numbers they first use, and it's important that they don't become entrenched in using the wrong or indeed superseded units. Without action in these areas, LPA testing and management risks become another promising area of health innovation where the UK is falling behind comparative systems. Prominent, and I make this comment, and I think we need to look further afield and work with other countries that are doing it. When I met the Shadow Minister, I said to him this morning the same thing. Prominent European and American guidelines, such as those from the American Heart Association, National Lipid Association, European Atherosclerosis Society, have all set out the importance of considering LPA as part of CVD prevention approaches, with some countries even thinking practically about how universal LPA screening could be introduced. The present approach, therefore, puts us at risk of missing a rare opportunity to save lives that may be cut short by CVD, and will also be increasingly out of line with government's focus on transforming prevention across the NHS. The LPA task force, I'm coming to the end, Mr. Chairman, is a coalition of experts from across the cardiovascular, lipid and laboratory community, comprising membership from all 4 nations of the United Kingdom. And they have come together to help tackle this lack of awareness and set out the value of testing for LPA in routine clinical practice to improve CVD management. Chaired by Heart UK, the group published their calls on Action 2023, August 2023, and have since been working with key stakeholders to set out the potentially transformative role that LPA could play in the future, and more broadly to help renew the UK status as a world leader, and we can be the world leader in CVD prevention and care. I would ask the Minister some questions, and I finish with this. If there's a willingness to meet with myself, Minister, and representatives from the LPA task force to discuss the essential steps that need to be taken, and other members who are here, by the way, who have an interest in this subject, to ensure that the UK is in the best possible position to integrate LPA testing and management as a core part of CVD prevention strategies. And further, can the Minister commit to engaging with key system partners such as NICE, as the NHS in England, and devolved administration to address relevant policy barriers that could hold back progress in the area, ever mindful that the LPA task force already comprises the 4 nations of the United Kingdom. I believe government must take wider action through its forthcoming 10-year health plan to secure renewed focus on CVD prevention, underpinned by ring-fence funding, enhanced early detection, expanding community diagnostic capacity, timely implementation of evidence-based guidelines, and comprehensive public awareness and patient empowerment programmes. And finally, Mr. Chairman, will the Minister explore the scope to develop a dedicated national strategy for cardiovascular disease? We had that in 2019. I believe we need it in 2025. And reversing these worrying trends in CVD, I believe, and the outcomes is one of the great healthcare challenges that we face over the course of this Parliament, and must be approached with the necessary focus and attention. The UK must be able to capitalise on new and emerging areas such as LPA, which will be crucial if the UK is to renew its status as a world leader in CVD prevention and care. Just like cancer, one in two people in this hall today are likely to develop heart and circulatory conditions in their lifetime. And just like cancer, the CVD community would welcome a commitment from the government, from the Minister, to publish a dedicated national CV strategy. And I suppose at the end of the day, Mr. Chairman, that's the big thing I'm asking for. Thank you.
Thank you, Mr Shannon, and I now call Sonia Kumar.
I'd like to thank the member of Strangford for securing this important debate.
I'm afraid I was too quick to call the Honourable Lady because I was very keen that she should speak, but I should have put the question, which is that this House has considered the prevention of cardiovascular disease. Sonia Kumar.
Thank you, Chair, and I'd like to thank the member of Strangford for securing this important debate. Cardiovascular diseases is just a word heard far too often in family circles and large communities, and even on a national scale. Causing 1 in 4 deaths in the UK, cardiovascular disease is causing many misery across many families. In Dudley alone, 10,000 people are living with heart conditions and circulatory diseases. Across the Black Country ICS, 11,000 people are waiting for cardiac treatment, and nearly 5,000 of them are already waiting longer on the NHS targets. The numbers translate into our everyday lives. This includes strokes, peripheral heart diseases, diabetes and heart conditions. Every delay means more emergencies and, tragically, more preventable deaths, and we must act now. Prevention and early intervention are critical in combating cardiovascular disease. We know that obesity, high blood pressure and smoking are risk factors. Higher than the national average in Dudley, 30% of adults are living with obesity, and that 16% are still smoking. And I welcome the government's initiatives to tackle smoking and weight loss, and I believe that addressing and diagnosing the conditions, cardiovascular conditions, will help our population live healthier lives. However, our experts in cardiovascular care isn't just our fantastic doctors, but it's also our AHPs, so our allied health professionals. As a physiotherapist by trade, AHPs have a big role in diagnosing and managing cardiovascular diseases, and as a physiotherapist, I will screen for cardiovascular conditions which can masquerade as musculoskeletal conditions. I will check blood pressure, cardiac pulses, auscultation, vascular exams, neurological conditions, and also cranial nerve testing of the face. Physiotherapists aren't just involved in assessments, but also in rehabilitation, like places like Action Heart in Dudley, which are inundated with referrals, where patients are getting excellent care for cardiovascular rehabilitation and preventive programmes. My podiatry colleagues who will check peripheral vascular disease, diabetic foot, are a foundation of knowledge. My OT and speech and language therapists who do exceptional work with stroke patients. My radiology colleagues who will help with diagnosing these conditions. And my paramedic colleagues who will manage these patients in acute care when they most need it. I could talk about AHPs all day as an AHP myself, but I want to present some recommendations and steps that I feel the government could take to make a big difference in this area. The importance of a multidisciplinary team, so ensuring that AHPs are at the centre when making policy decisions and announcements. And this isn't just with cardiovascular conditions, but it's all conditions. It's not just tackled by doctors. 2, ensuring diagnosis and checkups are in GPs. So when we're looking at GPs, we're looking at first contact practitioners, that's podiatrists, paramedics and physiotherapists that also work in that primary health care. We're also looking at pharmacists who can do the simple checks to check blood pressure early on. 3, by substantial and ring-fencing funding for local health systems to scale up successful CVD scale risk management programmes is essential for us to move forward. This should include cardiovascular rehabilitation, prescription of gym memberships in the community to ensure that those that need the care have structured long-term support with an emphasis on healthier lifestyles. We owe it to our communities, to the NHS, but most of all, the thousands of people living with cardiovascular disease that we need change now, and let's not wait for more lives to be lost.
I now call Jas Athwell.
Thank you very much. And can I say what an honour it is to serve under the chairmanship of such a multi-talented, multifunctional chair. And I'd also like Can I also thank the Honourable Member for Strangford for securing this debate. It's very important. Cardiovascular disease changes lives, it takes lives, robs families of loved ones. And I can speak from personal experience. My father has been gone 29 years because of cardiovascular disease, and my mother 28 years. So it absolutely robs families of loved ones. Across the UK, cardiovascular disease alone is responsible for 1 in 4 premature deaths. Beyond the personal impact the disease has on families, cardiovascular disease also places an enormous burden on our NHS, costing over £7.5 million per year. Preventative medicine, early detection can save lives, keep families together and reduce the burden on our NHS. Whilst preventative measures can take many different forms, which my colleagues have addressed today, I would also like to focus on early diagnosis. I know personally how critical early diagnosis can be. In 2023, having cycled 85 miles on the Sunday, I felt the healthiest and the strongest I'd ever felt in my life. But one precautionary test taken purely to reassure myself that I was fit shattered my illusions and changed my life, but ultimately saved it as well. I was diagnosed with chronic heart disease. Within weeks, I had a triple heart bypass. Had I not taken that test, I believe I would not be here today. Early detection saved my life, and it can save millions more. In my constituency of Ilford South, a community-based study was conducted across 4 GP practices by Dr. Lashkar and Professor Lloyd from Bart's Hospital. Non-specialist healthcare workers used handheld echocardiogram devices to screen 518 local people. They found 22% of those screened were referred for specialist assessments. This is 1 in 5 lives potentially saved. This study in Ilford South demonstrates how we can detect serious conditions early without requiring expensive hospital visits later. As my colleague just said, prevention and early intervention saves lives. By investing in local healthcare services and using tools like the handheld echocardiogram device, we can catch problems sooner, treat people faster, and relieve pressure on our overstretched hospitals sooner. Early diagnosis is not just a medical advantage, it is life-saving, delivering more time with loved ones, less strain on our NHS, a future where fewer lives are cut short. We have a golden opportunity to prolong life, give the gift of life, and I urge the Minister to grab this opportunity with both hands. Thank you.
Thank you, and I now call Alison Bennett, the Liberal Democrat spokesman.
Thank you, Mr Mundell, and it is a pleasure to serve under your chairmanship today. And I would like to begin by congratulating the Honourable Member for Strangford for his characteristically detailed and impassioned speech to open this debate. Cardiovascular disease, or CVD, affects around 7 million people in the UK, making it a significant cause of both disability and premature death. And as the Honourable Member for Ilford South has just shared, it has impacts on many of us, and for me, in my family, my paternal grandfather, Lance, died of a heart attack in his 50s. My maternal grandfather, Bill, died of an aortic aneurysm in his 80s. And 13 years ago, my father, Hugh, had a triple heart bypass and happily survived and is doing well 13 years on. So I'm enormously grateful to the NHS for what they did to save my father's life 13 years ago. But it is the case that much more needs to be done to prevent the impacts of cardiovascular disease across so many people in the UK. But we know that there are a huge variety of causes of cardiovascular disease, and one cause for which we have the solutions is that of socio-economic disparities. The truth is, those who live in the most deprived areas of our country face a far greater risk. People in the 10% most deprived communities are almost twice as likely to die from CVD as those in the least deprived areas. There is clearly work to do to close this gap. It seems unfathomable to me that in a small and supposedly prosperous nation, a man living in Kensington and Chelsea can now expect to live 27 years longer than a man in Blackpool. That's not just alarming, it's unjust. And this disparity worsens when we look at the population with severe mental illness. For people with extreme mental illness, their life expectancy is 15 to 20 years lower than the general population, and they face a 53% higher risk of CVD. The previous Conservative government's lack of support exacerbated these health disparities. Public health funding was cut by 26% in 2015, leaving local authorities unable to provide vital services. With the new government showing some signs of genuine investment in the right places, I believe this can change. It must change. My Liberal Democrat colleagues and I are committed to creating a healthier and more equal society. The UK has long been known for its grassroots sports, high-quality food production, and world-leading medical research. We should be one of the healthiest countries in the world. Under the previous Conservative government, however, the country became sicker, lagging far behind our international peers. That's why we Liberal Democrats are calling on the new government to take urgent action to support people in leading healthier lives, reversing the Conservative cuts to public health funding. I firmly believe that improving public health is not just about treatment. In fact, far from it. It's about empowering people to live healthier lives, creating healthier environments, and supporting communities in making decisions that improve their health. In doing so, we will take pressure off overburdened systems and create a more resilient population. We have several steps that we would like to propose to address this, including the reversal of cuts to the public health grant, enabling local authorities to provide essential preventative services. Second, the setting aside of a proportion of the public health grant for those experiencing the worst health inequalities to co-produce plans for their communities. And third, the establishing of a health creation unit in the Cabinet Office to lead work across government to improve the nation's health and tackle health inequalities. Our vision for the future also includes addressing the obesity crisis. The National Institute for Health and Care Excellence found a direct correlation between deprivation and both adult and childhood obesity. That's why we are calling for an end to the 2-child limit and the benefits cap, which would lift over 500,000 children out of poverty. We would expand free school meals to all children in poverty and work to ensure that every primary child has access to a healthy meal. We must also protect our children from the harmful effects of ultra-processed food advertising and encourage healthier lifestyles by supporting walking and cycling. Our transport networks need to be redesigned to prioritise active travel and road safety, ensuring every community can access safe spaces for walking and cycling. My Liberal Democrat colleagues and I are committed to making the UK a healthier and fairer place to live. We know that investment in prevention, public health and primary care is key to tackling the root causes of cardiovascular disease and improving the lives of millions across the nation. The issue is solvable and we have the answers. We just need to do it. Thank you.
And I now call Dr. Luke Evans on behalf of the official opposition.
Thank you, Chair. And before we start, I think it was Gandalf who said, "A wizard is never late nor early. He arrives precisely when he means to." And I think it would be protocol you have to be here at the start of the debate. But I certainly, for one, would like to see the Minister sprinkle his magic on this topic, because I hope he's going to give some enlightening answers to such an important debate. And I'd once again like to thank the member for Strangford for his industrial strength in always securing these debates. I believe it's said that the man who moves a mountain begins by carrying away small stones. And if he was to be judged, he is literally moving the health metaphorical mountains, one Westminster Hall debate at a time. And I raise my hat to him because this is at least half a dozen times I've now had the chance to respond to him, and he always conducts himself in an incredible manner with incredible detail, so I thank him. If we can tackle the risk factors behind cardiovascular disease and identify it in an early stage, we can make significant differences to reducing the number of people lost to premature deaths every year. The member for Ilford South movingly spoke about his mother and his father, and that was followed up by the member from Mid Sussex as well, about her father 13 years on, and he will be very proud to see his daughter here, and of course I'm sure the member for Ilford South parents would be proud as well of their achievements to be raising such an important topic. Now, I myself come to this topic as a GP, and this is pretty much bread and butter life of a GP, advising on healthy lifestyles, managing blood pressure, angina, obesity, smoking, heart failure, strokes, and many, many more conditions. And I pay tribute to my honourable friend from Dudley, who points out how important this is. It's not just the doctor's role anymore. This is the MDT approach. And actually, a quality MDT really helps the GP be able to understand where they need to look and manage that workload, which is so important, not just for the clinicians, but most importantly for the patients. So it's an honour to take part in this debate and help shape it. Now, firstly, from the public health perspective, the last government made significant progress on things like calorie labelling, salt and sugar reformulation, smoking cessation, which are all contributors to cardiovascular disease. It was just 3 years ago that the NHS published its CVD prevention recovery plan, setting out 4 high-impact areas for every part of health services to focus on risk factors, detection and management, for example, rolling out of blood pressure checks in high street pharmacies, which we heard about, and allowing people to measure blood pressure at home. The NHS long-term plan set out 5 ambitions to detect and treat people at risk of developing CVD, which has been revised twice in 2022 and 2024. This work was reinforced by the introduction of the NHS Digital Health Check in spring 2024, which aimed to prevent 400 heart attacks over 4 years. Now, the National Audit's Office report into CVD, published in November 2024, said the disruption to the NHS caused by COVID pandemic has had substantial impact on elective care. And this has undoubtedly had an impact on the prevention and treatment of cardiovascular disease. We don't have to look back too far to think about lockdown and the effect that had on people's both their physical activity, but their ability to seek help, and some of this preventative and advisory medicine that would have normally taken place. So following the NIO's report, the government committed to reviewing the NHS Health Check programme. Could I ask the Minister that they confirm the timescales for this review and when the reports will come on the outcome? Now, the member for Strangford rightly points to cholesterol and lipids, which often isn't given the attention it needs. And it's hugely important when you're dealing with addressing cardiovascular disease. So I thank him for putting that up. And I myself, if I take my own constituency, have been doing casework on this very topic as a backbench MP. The Honourable Member for Strangford mentioned lipoprotein A in his speech, and I've been questioning ministers about the development of genetic testing for familial hypercholesterolemia, the development of a familial hypercholesterolemia service in Leicestershire. And while this is a complicated and involving space, given the great advances in testing and understanding of lipids, it's really important we do get to the bottom to understand the environmental impacts that are causing this, but also the genetic ones at play too. To that end, the work has also included looking at how bodies can track patients and the current difficulties in familial hypercholesterolemia services on cascading to local people's relatives, which I think is what the member for Strangford was pointing towards. So it is probably beyond the scope of this debate, but given the success for the member of Strangford, I wonder if he is lucky enough to table for a backbench debate on lipids, it would be a great thing to achieve. But I would take the opportunity to ask the Minister whether he would consider asking the department to look at improving the clinical pathways for familial hypercholesterolemia and the possible rollout of screening for both patients and family members. I, of course, do appreciate this has to be done on an evidence-based approach. Now, Mr. Chairman, more people are living with multiple long-term conditions. That's no different for many people living with CVD who are also living with other conditions like diabetes. That's why the last government was developing the major condition strategy to try and improve outcomes across major conditions, including cardiovascular disease, but cancer, diabetes, respiratory disease, mental health and musculoskeletal disorders. Since the general election, ministers have decided to go in a different direction. So could I ask the Minister to reassure me that in the NHS 10-year plan, he will address the impact of these long-term conditions? And as the member for Mid Sussex pointed out, inequalities really does play a role when it comes to cardiovascular disease. So I'd be grateful if he'd comment on that. Chair, I think the quote goes, "Study the past if you would divine in the future." And I'm always keen to gain insight from across the House of what's previously happened. So I did note that almost a year ago today, there was a debate held in the main chamber called Heart and Circulatory Disease by the then MP for Watford, the brilliant campaigner Dean Russell, who himself talked about his experience of having a heart attack. Of course, the debate was a few months just before the general election, but it gives us a good insight of what the then Shadow Health team were thinking about when they came to government, which they were successful in doing so. The Shadow Minister for Bristol South, and now Health Minister, was responding, and she said, quote, "Labour has a mission to reduce death from heart attacks and strokes by a quarter within 10 years. Under our Fit for the Future fund, we would double the numbers of scanner, speeding up heart and circulatory disease diagnoses." So could I ask, what is the amount in this fund? Has it been deployed, and what is the timescale? And what scanners were specifically commissioned for cardiovascular disease? She went on, "We would also incentivise continuity of care in general practice, which would improve care in our communities for people living with heart and circulatory disease." Now, you don't have to tell me as a GP about the importance of continuity of care. So could the Minister explain to me how this would look like in the GP contract, and what incentivisation is being considered for GPs? The Shadow Minister then went on, and I quote, to say that that is why Labour will introduce a child health action plan that will put prevention at the top of the agenda. Now, forgive me, but looking on the government's website, speaking to the House of Commons library, I can't see a report or a plan that has been produced on this topic. So I'd be grateful if I have missed it, the Minister would provide one. If not, if he would put out the goals and timelines for this achievement to be achieved, if the department would provide one and place it in the House of Commons library. When it comes to research, the then Shadow Minister stated that is why Labour's Regulatory Innovation Office would make Britain the best place in the world to innovate by speeding up decisions and providing a clear direction based on our modern industrial strategy, alongside with a plan to make it easier for more patients to participate in clinical trials. Now, Mr Chair, 8 months into the new government, and I believe a chair hasn't been found. So could the Minister update me on when this role will be filled? And if, given this was the stated aim by the Labour Party in the CVD debate, what conversations he's having with DCIT about speeding up cardiovascular trials? Now, in closing, Chair, I thought it fitting to use the lines of Dean Russell, who back then pointed to data, education, protection and research in his closing remarks when it comes to dealing with cardiovascular disease. And I think that's something this entire House can get behind. And the member for Ilford South, in his own story, is a testament to the life advice that Dean gave to us then. And I quote, "And if anyone at home is worried, they should get checked. If they're concerned that they have symptoms, they should get them looked at. It is better to get rid of fear before the event than to wait for them to become a reality and have to deal with the outcomes of that." And I think, Chair, we can all agree on that too.
Thank you. Minister, I'm sure you're going to begin with an apology to me, to Mr Shannon as the instigator of the debate, and all the other participants, because it is very clear on the order paper that these proceedings began at 3 p.m.
Thank you very much, Chair, and it's a great pleasure to serve under your chairship. I am indeed starting with an apology. I'm very embarrassed by the fact that this was put in my diary by my officials to start at 3:30, and it's completely unacceptable that I arrived late. I apologise to you. I apologise to the honourable member who secured this debate. It's a very embarrassing situation, and I'm not happy about it at all. I thank the Honourable Member for Strangford for securing this debate on such an important issue and for the vital work he does as the chair of the APPG on vascular and venous disease. I also thank the other excellent contributions that came from my honourable friend, the member for Dudley, who spoke powerfully based on her extensive real-world experience and expertise, and my honourable friend, the member for Ilford South, who spoke so movingly about his family and personal experience, and the honourable member for Mid Sussex spoke passionately about the shocking health disparities that blight our country, caused by 14 years of Tory neglect and incompetence. Before I begin my remarks, I want to pay tribute to people working in local government, our NHS staff and GPs up and down the country for their efforts to find, treat and manage people at risk of cardiovascular disease, also known as CVD. As the honourable members will know, health is a devolved issue, and so my remarks will be limited to matters in England. However, I'm happy to pick up on many of the broader points the honourable gentleman has made. Mr. Chairman, the last Labour government made significant progress on reducing premature deaths from CVD through the introduction of higher impact interventions such as the ban on smoking in public places and increases in statin prescribing. However, as the honourable gentleman made clear in his remarks, among the many, many appalling findings of Lord Darcy's report, there is clear evidence that progress on CVD stalled and even went into reverse in some areas between 2010 and 2024. That's why it's this government's mission to invest in the health service alongside fundamental reform to the way that healthcare is delivered. We will build a health and care system fit for the future by moving from sickness to prevention, from hospital to home and from analogue to digital. And tackling preventable ill health is a key part of these shifts. As part of our 10-year health plan, we're committed to helping everyone live a healthy life for longer. And as the honourable gentleman outlined in his remarks, too many lives are cut short by heart disease and strokes. In 2022, a quarter of all CVD deaths in the UK occurred in people under the age of 75. Tackling CVD is not just the right thing to do for patients, it is also impacting on growth. People with CVD are more likely to leave the labour market than people with poor mental health. And we must dispel the fiction that people with CVD are always old and infirm. Around 1 in 3 people who have a heart attack, 1 in 4 people who have a stroke, and 2 in 5 people with coronary heart disease are of working age. The honourable gentleman made reference to figures on premature deaths in his remarks. And the most recent figures I have for 2023, we know that in England alone, over 130,000 people died from CVD and over 30,000 people died before they turned 75. The best estimates show that CVD's annual cost to the NHS is a staggering 8.3 billion, with knock-on effects of 21 billion to the wider economy. This is a huge challenge, and that's why we're meeting it with great ambition, to reduce premature deaths from heart disease and stroke in people under 75 by a quarter within a decade. My honourable friend, the Minister for Public Health and Prevention, will be spearheading our work in this area and will also be picking up on many of the issues that the honourable gentleman raised in his speech. Now, we know that 70% of the CVD burden is preventable and due to risk factors such as living with obesity, high blood pressure, high cholesterol and smoking, all of which can be reduced by behaviour changes, early identification and treatment. In England, the NHS Health Check is a free check-up for people between 40 and 74. The NHS Health Check is a wide-reaching programme delivered by local authorities in England. This CVD prevention programme aims to prevent heart disease, stroke, diabetes and kidney disease, and also dementia for older patients. Mr. Chairman, in the very short period of time that I have left to me, I just wanted to say the honourable member for Strangford called for the introduction of LPA tests. As I understand it, lipoprotein A measurement is not currently recommended by NICE guidance, and there are no treatments available which specifically target LPA. Instead, our focus is to improve the uptake of lipid-lowering therapies for prevention of CVD and to treat people with established CVD to NICE treatment targets. We will look closely at new tech and innovation and the essential role they'll play in reducing health inequalities.
Can Minister, I apologise but at the end I'd asked for three things. I'd asked would there be a willingness to meet with me and representatives from the LPA task force to discuss the essential steps that are needed, and I asked that. Sorry.
These proceedings go on to 4:30, so there's no need for you to try and speak in a very short period of time.
I'll not test your patience, Mr. Chairman, by speaking to 4:30. I'll test the patience of everybody was do that, but if I can just maybe sum up, if that's okay.
Yes, but that's what I was saying. But I felt you were summing up in a way that anticipated we're concluding at 4.
I'd asked for intervention, but I didn't realise that the Minister sat down. First of all, can I thank all members for coming along, and the Honourable Lady for Dudley set the scene incredibly well. With her knowledge and her experience through work, I think the Minister referred to the real world experience, and we heard that at the end. We thank her for her contribution as well. She's certainly establishing a name for herself in the Chamber, and we thank her for that. Honourable Member for Ilford South, there's no better way of telling a story to illustrate the point you're trying to make than a personal story. The Honourable Gentleman did that personal story in a way, and it reminds me of one of my constituents. He came to see me one day, and I know him very well. He's a man. He's in a different political party, but I just asked him how he was, and he says, "Jim," he says, "I went to see my doctor. I thought it was okay." Before he finished the test on me, he gave me a bit of paper, and I said, "What's that for?" He says, "You have to go to hospital right now." He went and had a quadruple bypass, and he was perfectly healthy, and he didn't know it. So I thank him for sharing that there. Honourable Lady for Mid-Sussex very clearly underlined the differential. For someone in Kensington and Chelsea can live for 20 years longer than one in Blackpool. Well, that's got to be wrong, and we've got to address those issues. And they also mentioned the issue of obesity in children, better food, better meals at school as well, to improve the public health, to live healthier lives, and to deliver more resilient people. The Honourable Gentleman, the Shadow Minister, from a member for Hinckley and Bosworth, again referred to genetic testing, to the cascading of the tests right down to the families, which is one of the things that I'd asked for. He referred to the 10-year plan again, and that long-term conditions of CBD needs to be part of that. The aims of government seem to indicate that there will be a wish to do those things in relation to CBD, and we very much hope that the Minister can do those things. And I thank the Minister for arriving. And it's always, look, things happen in life. Things happen to me. Sometimes I'm late for things as well. Probably my fault on most occasions, Mr. Chairman, and I take the blame. But anyway, on this occasion, the Minister's been here. I asked for three things. I was hoping to have them. I'll repeat them again for the purpose of the three requests that I had. Asked the Minister if there's a willingness to meet with me and representatives from the LPA task force to discuss the essential steps that need to be taken now to ensure that the UK is the best possible position to integrate LPA testing. And will the Minister commit to engaging with key system partners such as NICE, NHS England and devolved administrations to address relevant policy barriers that could hold back progress, ever mindful that the LPA task force has already integrated the 4 nations of the United Kingdom in what they are doing. I always try to be positive. You know the person I am, Mr. Chairman. My objective coming here is not to catch anybody out. I just want a positivity and a solution-based end to what I'm asking for. And ever mindful that the last one was that would the Minister explore the scope to develop a dedicated national strategy for cardiovascular disease. Those are my 3 requests. Put forward genuinely, sincerely, honestly and kindly. And I would ask that the Minister could let us all know in this House here today as outcomes of that there, because I think that others in the House from different parties perhaps would like to know as well what the policy is. Thank you so much.
I'm sure the Minister will have heard the 3 points that Mr. Shannon raised, and on that basis then I will put the question. Yes, Dr. Evans.
And in perfect symmetry we have systems for dealing with cardiovascular disease, but as has been proven today, this debate has taken a somewhat different pathway in terms of procedure, which is what patients do indeed with cardiovascular disease, and that things surprise you. My concern is that some of the questions that were raised by myself as His Majesty's opposition have not had the chance to be raised. I'd be grateful if the Minister would take them away with him and write to me. If I was perhaps able to put them in a letter, is that within the scope of his chairmanship to allow that to be the case?
Well, it's not technically a point of order, but I'm sure the Minister will have heard what you had what you had to say. I'm sure the Minister and indeed Dr Ahmed, who was here from the start, will have noted all the points that Mr Shannon raised during his contribution, and if none were, if those points that Mr Shannon raised at the end and indeed earlier in his contribution before the Minister were unaddressed, I'm sure the Minister will write to him. Minister.
Absolutely will. I do have more to... I'd be happy to complete my remarks, sir, but I don't know how that works, given that Mr Shannon...
I will make the determination that Mr Shannon's contribution was an intervention, although an excessively lengthy one, which he will not repeat at the conclusion of the debate. Minister.
Thank you very much, and this has been an interesting debate on so many levels, and I thank you for that clarification, Chair. So I was just talking about the fact that around 70% of the CVD burden is preventable, and the causes obesity, high blood pressure, high cholesterol and smoking. All of that can be reduced by behaviour changes, early identification and treatment. In England, the NHS Health Check is a free check-up for people between 40 and 74. The NHS Health Check is a wide-reaching programme delivered by local authorities in England. This CVD prevention programme aims to prevent heart disease, stroke, diabetes and kidney disease, and also dementia for older patients. It engages over 1.4 million people a year, and through behavioural and clinical interventions prevents around 500 heart attacks or strokes annually. I agree with the Honourable Member for Strangford that the report from the National Audit Office does indeed show there is still so much more to be done. And that is why we've asked officials to be more ambitious and to develop policy proposals on how the programme can go even further. In the meantime, we're focused on delivering a new digital NHS health check available through the NHS app so people can assess, understand and act on their CVD risk at home. We want to make it easier for people to access the programme, especially for our constituents who have caring or childcare responsibilities or who can't easily get to their GP surgery during opening hours. The creation of a state-of-the-art national digital NHS check service will improve access to this life-saving check. Mr Chair, the member for Strangford is right to mention diabetes as a key risk for CVD. Each year, the NHS Health Check identifies 22,000 people with high blood sugar who are referred on to primary care for further assessment and management. GPs can refer people at risk of developing type 2 diabetes into the Healthier You NHS Diabetes Prevention Programme. This programme has been highly effective. 35,000 people have been referred by their GP. Over 20,000 have started the programme since September 2020. For people who complete the programme, it can cut the risk of developing type 2 diabetes by 37%. And for people who already have diabetes and are overweight or obese, the NHS Type 2 Path to Remission programme is available. This joint initiative from NHS England and Diabetes UK aims to support eligible people with type 2 diabetes 2 achieve clinically significant weight loss, improve blood glucose levels and reduce the need for diabetes-related medication. A recent study found that almost a third of patients with type 2 diabetes who completed the programme went into remission. Around half of heart attacks and strokes are a result of high blood pressure. A third of adults have high blood pressure, and worryingly almost a third of these are currently untreated. This means that over 4 million people do not know that they have high blood pressure. It is often referred to as the silent killer, as high blood pressure is largely symptomless. The tragedy is that the treatment is so cheap and effective. We could prevent around 17,000 heart attacks and save more than 20 million in healthcare costs alone over 3 years just by treating 80% of patients on target. Now, the Honourable Gentleman also mentioned high levels of cholesterol as a key risk factor in CVD. For every 3 NHS health checks delivered, one person is found to have high cholesterol. And there are well-known health inequalities in CVD affecting underserved communities in England. Addressing undetected and poorly managed high blood pressure and raised cholesterol are key to preventing CVD and reducing health inequalities. Now, there are effective drug treatments. Statins are readily available and very cheap. They can reduce an individual risk of CVD in 4 to 6 weeks. If we improve treatment rates for people with CVD to 95%, over 18,000 CVD events, such as heart attacks and strokes, may be prevented over 3 years. We will be looking closely at how we can get this done. Now, the Honourable Member for Strangford has called for the introduction of LPA tests, and as I mentioned earlier, this is not currently recommended by NICE guidelines. I have taken account as well of the detail of his other remarks in terms of his requests around a meeting, engaging with system partners and the other requests. My honourable friend, the member, the Minister of State for, or the Minister, sorry, for Prevention and Public Health will be taking all of those requests on board. I think it's right that she's the right person for him to meet with, given that she's leading in this policy area. Turning now to smoking, we know that smoking costs health and care services £3 billion a year, resources that could be freed up to deliver millions more appointments, scans and operations. The cost of smoking to our economy is even greater, with around £18 billion lost in productivity every year, with smokers a third more likely to be off work sick. That's why we're taking forward the Tobacco and Vapes Bill, the biggest public health intervention in a generation, breaking the cycle of addiction and disadvantage and putting us on track towards a smoke-free UK. This will make a real difference in constituencies where smoking contributes to the cycle of poverty and ill health. And we're supporting the local stop smoking services with an additional £70 million investment this financial year. Mr. Chairman, I think today's debate has shown what a challenging and complex area this is. The honourable gentleman for the opposition has also raised a range of issues, and I absolutely will undertake to ask my honourable friend, the Minister for Public Health and Prevention, to write to him on all of those points. I think many of his points are best dealt with in correspondence. I will give way.
Thank you very much. I thank the Minister for giving way, who's making powerful points. In taking the holistic approach, would the Minister agree that perhaps looking at a more wider holistic approach, taking into account planning and taking into account advertising, for instance, children going to school, having access to the proliferation of chicken shops, fast food shops, and also being exposed to 13 to 15 on average advertising of junk food is perhaps something we should also take into account, which will help in limiting the number of heart diseases that are caused later on down the line. Thank you. Yes.
Well, I thank my honourable friend for that intervention, and he is absolutely right that the focus of prevention should be as early as possible in the life of our young people, and bad habits form at early ages. That is not helped by the behaviour of some aspects of our economy and the way in which products are advertised. And I think it's absolutely essential that we move to a model of prevention which is a partnership between the government and our communities and business. We are taking action against advertising of certain products before the 9 o'clock watershed. We're also cracking down on energy drinks, which are really pernicious in terms of the amount of sugar, caffeine, and other deeply unhealthy components that they have. So he is right that this is something where we genuinely are all in this together. We need that partnership with the private sector. We need a change in the mindset around healthy and nutritious food, and that needs to be put into schools through community health, also working with parents and communities to just change the habits of our country effectively. And that is a gargantuan challenge that we have ahead of us. But I think our government is absolutely committed to that, and that prevention strategy is going to be at the heart of our 10-year plan. It's one of these key shifts from sickness to prevention. So really, that leads me into my closing remarks, which is that we have seen today what a challenging and complex area this is. It's a challenge that requires sustained action on a number of risk factors, but I can assure colleagues that this government will leave no stone unturned in getting premature deaths from heart disease and stroke down by a quarter for people under the age of 75 within the next year. In my contribution, I've sought to demonstrate our commitment to getting on with the shift from sickness to prevention, with our cast-iron commitment to expanding NHS health checks, the shift from hospital to community by making it easier for people to get checks at their convenience and at home, and the shift from analogue to digital through an innovative and expanded digital service. So I once again would like to thank the Honourable Member for bringing this important debate forward, and to thank all Honourable Members across all sides of the House for their excellent contributions, and watch this space. We will continue to work on this issue with focus and at pace. Thank you, Mr. Chair.
And do you wish to make a final contribution?
Quite sure what happened there, but anyway, Mr. Chairman, just say thank you to everyone. Thank you to the Minister. Thank you to all the honourable members who made a contribution, to the Backbench Committee for making it possible. And today we look forward to the delivery that government has indicated in the years ahead, and one that all the nations of this great United Kingdom, Great Britain and Northern Ireland can work together on. Thank you so much.
It's been a little unconventional, but I think we did get there in the end. So the question is that the House has considered the prevention of cardiovascular disease. As many as of that opinion say aye.
Aye.
Of the contrary, no. I think the ayes have it. Order. The sitting stands adjourned.